Bismillah ar-Rahman ar-Rahim. Today's lecture is about the memory manifestations of systemic disorders. And this entity is very important because sometimes we have systemic disorders affecting the breast and we could not diagnose. The breast is just a part of the body, so a variety of benign and malignant pathologies may affect the female breast. These lesions may originate from the breast tissue itself or from anatomically related tissues present in the breast. Unusual lesions of the breast can pose a diagnostic challenge. These unusual lesions include systemic diseases that infrequently involve the breast, but mammography findings may be striking. Neoplastic diseases. The first lesions that affect the breast, and very important to know, is the neoplastic diseases of the hemobiotic and lymphoid tissue. Breast lymphoma, either as a manifestation of primary extranodal disease or as secondary involvement, is a rare malignancy in the breast. The reported incidence of the primary breast lymphoma range from 0.04 to 0.5% of all breast malignancies, and that of secondary breast lymphoma is about 0.07%. So it's very not common an entity to affect the breast. Secondary breast lymphoma is the most common metastasis to the breast, accounting for 17% of metastatic diseases of the breast. Primary breast lymphoma usually present by this shape: a solitary oval circumscribed mass, as seen in this case, in the lower central breast, and this is craniocaudal and mediolateral oblique view. Some of you will tell me how to know that it is breast lymphoma. In the primary breast lymphoma, usually the diagnosis is by pathology. Because being rare, you usually describe this as Peyraud's 4 lesion with indistinct borders in part. The hair border is indistinct, and there is associated mild architectural distortion, so this is a Peyraud's 4 lesion. Being rather well circumscribed, many differential diagnoses can be in this case. Maybe mucinous tumor, maybe phylloids. So breast lymphoma is usually in these cases diagnosed by biopsy. Primary breast lymphoma, this is by mammogram. And this is primary breast lymphoma by ultrasound. It is rather well defined, hypoechoic, a solitary oval, well circumscribed mass, and the ultrasound image show an oval indistinct mass with mixed echogenicity, and the very important is the increased vascularity. This increased vascularity warrants that it is not a benign lesion, it is a malignant lesion. Another case, this was a 70-year-old female presented to us by a hard breast mass. Right craniocaudal mammogram show a dense, well-circumscribed mass with lobulated outline. And on ultrasound examination, we have there is a mass and there is another mass beside it. So it was a multilobulated mass, and it does not contain calcification and no surrounding architectural distortion. And by biopsy, it was primary Hodgkin lymphoma. And it's common in that age. Breast lymphoma on mammogram appear as a solitary mass in 69 to 76% of cases. The shape is predominantly oval or round. The lesion margins are non-specific, commonly circumscribed and indistinct, and speculated margins are rare in the case of breast lymphoma. A hyperdense appearance is seen in 85% of breast lymphoma on mammogram, Asymmetries are infrequent imaging findings of breast lymphoma detected in the rest 20% of cases. Mammographically apparent skin thickening and lymphedema are rarely identified in cases of lymphoma. You know, here this is breast mass, and even when there is axillary lymph node, we will see later in the lecture, in most frequently we didn't find associated skin thickening, only present in 8% of cases. Architectural distortion is rarely identified and can be seen in up to 9% of lymphomas. Calcification are almost always absent in cases of lymphoma. This is another case of secondary breast lymphoma. We have a malignant looking axillary nodes. They are globular in shape, indistinct hilum or eccentric hilum. So this is malignant appearing lymph nodes. However, the breast appear completely normal. There is no edema, no associated skin thickening, normal breast parenchyma. So this is a case of secondary breast lymphoma in the axillary, affecting the axillary lymph nodes without affecting the breast itself. This is another case. This is a well-circumscribed mass. However, it has a tentacle-like appearance arising from the posterior part, so it is not benign looking on mammogram. It is suspicious. We give it PIRADS 4. This is the another seen in the other view. So this is PIRADS 4 breast lesion. On ultrasound, we can characterize. If you found this appearance in ultrasound, there is a thickened cortex, there is a fatty hilum but indistinct hilum. And when you found other lymph nodes like supraclavicular and cervical lymph nodes, then again we are talking about breast lymphoma. So the secondary breast lymphoma may affect lymph nodes either isolated in the axilla, or it can affect the intramammary nodes in the breast. Like in this case, it is an affected intramammary node but not affecting the breast parenchyma. Another case, this case complaining of right axillary lump. It's not well seen on mammogram. Maybe they are more deeper. And here on mammogram, on the parenchyma, we can see that we have breast ACRC, and there is nothing. But the first one who saw the case, see this ill-defined distortion, but it's not seen in the other film. And then he asked for MRI because there is pathological axillary nodes seen on ultrasound, and then we search on the primary on MRI. But here from the mammogram, we could not see, we see nothing. This is the case. MRI was done. And here we found that diffuse parenchymal enhancement with no enhancing lesions seen. And then we saw here the multiple enlarged globular lymph nodes seen in that axilla. There is no edema. And here, although the parenchymal enhancement is obvious, but there is no definite enhancing lesion seen. And here also, there is nothing in the breast, but we have the axillary nodes, multiple, amalgamated in parts, very large lymph nodes. So these very large lymph nodes with nothing in the parenchyma warrant to think of breast lymphoma, and the biopsy was breast lymphoma. Another case, multiple lymph nodes, multiple ill-defined lymph nodes present here, but although they have fatty hilum, they warrant suspicion, especially that this patient is known case of lymphoma. So here we have multiple intramammary nodes affecting the breast. Another case, she's a young female, 22 years old. MRI was done and she has do the sonomammography outside, and they gave her Piret's 4 lesions and asked for MRI, and that was the MRI. There is a mass here, multiple masses. This one in the axillary tail, morphologically suspicious also, because it has microlobulated outline, note here again. And this one rather well circumscribed, macrolobulated. This one also macrolobulated outline, but here this one show distortion, show here microlobulated outline. Here what we term the microlobulated appearance. This is the microlobulated, which is suspicious, not macrolobulated. And there is also tenting here, there is associated distortion, and then it is also Piret's 4 lesion. Here is the axillary nodes, but the axillary nodes, they are apparently normal. Anything else we can see here? Yes, there is anterior mediastinal lesion. There is anterior mediastinal lesion, also have the same appearance as the masses with lobulated outline. This is the anterior mediastinal lesion. Here also, this is the masses on T2. Here they were on T1, they're hypo intense, and there it's iso intense. And again we can see the anterior mediastinal lymph nodes here, multiple lobulated amalgamated يعني likely lymph nodal lesion. Is it thymic tumor or lymph nodes? I'm more that they are anterior mediastinal lymph nodes. So due to the presence of these anterior mediastinal nodes, we think of lymphoma affecting the breast. Because of the appearance, they are well circumscribed lesion, as we tell before, and the association of these anterior mediastinal amalgamated lymph nodes, we put the possibility that it is lymphoma. And here just a teaching point, very important. When you do MRI breast, not only look on the breast lesions, no, look on the whole thoracic cage and the extrathoracic manifestations of any breast abnormality. So this is the T1 and T2 of this case, showing multiple well circumscribed masses in the breast, bilateral, and the clue to the diagnosis here was the presence of the anterior mediastinal amalgamated lymph nodes. And here is the map. Here is the lesions. They are vascular, and the anterior mediastinal node lesions. Here, this is the post contrast. It's not so much enhancing. Usually the lymphoma is not markedly vascular. So these are the lesions in the different sequences. And this is the anterior mediastinal lymph nodes, multiple, amalgamated, consistent with breast lymphoma. And this is another case just I saw recently. She was a known case of cutaneous lymphoma, and when the patient came, I found many patches present on her skin, and they asked that if there is a parenchymal breast lesion or not. And here was the mammogram of this case. Here there is a pathological axillary node, I think bilateral, and in the breast parenchyma we could not detect a definite abnormality. There may be just a mild thickening here, but it's not definite. There is a scattered macrocalcific foci. but there is no parenchymal lesions or parenchymal distortion seen. Then we get the patient for ultrasound, and that was the appearance. Thickened skin with hypoechoic areas inside. First we thought that they are collection, but when you put Doppler, there is vascularity inside. This is the cutaneous infiltration by the lymphoid tissue. Cutaneous infiltration all through, many of them are present in this case, but the parenchyma of the breast was normal. So this is a cutaneous manifestation. Being the skin of the breast is a part of the skin of the body, so we have cutaneous lymphoma in the breast, and this is the pathologically enlarged axillary nodes. Markedly thick cortex with effaced hilum, but not totally infiltrated. Another case, 50 years old female known as hairy cell leukemia, and then came after time with breast mass. And the breast mass, this is the multiple lymph node affection. Here it is deep to the Reuters lymph node affected, and we have more deeper lymph nodes affected here. This is the rectus pectoralis minor muscle, and here we have multiple lymph nodes also, and there is a mass in the axillary tail, lobulated in appearance in the upper outer quadrant, so it is part of the pathology. It is a hairy cell leukemia affecting the breast and affecting the interpectoral and infraclavicular lymph nodes. Another case, we have a female patient, 48 years old, presenting with right marked breast edema. What we see on mammogram? Nothing. Marked increase in the density of the breast parenchyma associated with diffuse skin thickening, obliteration of the subcutaneous fan. So we give these cases Pirates 0 because I see nothing on the mammogram. On ultrasound, we have this typical appearance of these cases: markedly thickened skin, multiple well-circumscribed hypoechoic masses present underneath, just underneath the skin, all through the breast, also with axillary lymph nodes, and this is the typical appearance of metastasis to the breast. They are usually subdermal in location. They are usually well circumscribed and echopore, like in this case, and this case was metastatic adenocarcinoma, and she was of unknown primary until we diagnosed it. This is the multiple well circumscribed masses. So metastasis is the other, it's not common, but we must put it in our mind that these lesions may be metastatic from other origin. Metastasis to the breast occur in 0.5 to 2% of cases. Sarcoma, lymphoma, those uncommon breast tumors, adenoid cystic carcinoma and carcinosarcoma, or these are rare tumors, but we are talking now about the metastasis being spread from other part in the body in 0.5 to 2% of cases. Breast metastasis more likely multiple, bilateral, and often found in the subcutaneous fat. Common primary sites: melanoma, malignant melanoma, sarcoma, lung, coming from the lung, stomach, ovaries, kidney, and non-Hodgkin lymphoma, as the cases we have just seen. Radiological findings of breast, this is another case. She was metastatic from malignant melanoma. This case, she has a malignant melanoma in her little finger, which was excised, and after time she presented by the breast edema and this breast mass, and this is a subcutaneous nodule also here. It is a subcutaneous mass, and on color Doppler it shows high vascularity inside. So that was a case of malignant lymphoma. So the mammographic findings of breast metastasis: single or multiple masses, diffuse skin thickening, microcalcifications is rare in the cases of metastasis. On breast ultrasound, they have well circumscribed margins, low level echoes, and occasionally with posterior acoustic enhancement. Then we came to another entity very important in the breast diagnosis, is the autoimmune disorders. Autoimmune disorders are diseases caused by the body production and appropriate immune response against its own tissue. Systemic autoimmune diseases, including diseases as rheumatoid arthritis, systemic lupus, scleroderma, polymyalgia rheumatica, while localized forms include type 1 diabetes and multiple sclerosis and others. All these are the systemic autoimmune diseases. One of the common that we see in the breast affecting the skin of the breast, of course, and the subcutaneous tissue is the dermatomyositis. That was a case of dermatomyositis presenting to us by breast-like lumps in the breast due to the presence of this calcific foci. And this is the typical appearance of dermatomyositis affecting the breast. It affects the skin, so it is rising to the axilla as we see here. They are polygonal in shape calcification, so this is typical of dermal calcification. Dermatomyositis is a rare multi-system autoimmune collagen vascular disorders of adults and children of unknown etiology, primarily affecting the skin and the skeletal muscles. The classical picture of mammary dermatomyositis is extensive, bizarre subcutaneous dystrophic calcification. Another case. Here we know that it is a calcification. It is just subdermal in location. Note this one. It is related to the skin. Clues for the dermal. This is another case. Note here the calcification rising to the axilla. So the clues for dermal microcalcification, skin calcifications are most commonly seen along the inframammary fold. We see the calcification in the inframammary fold, and we see them rising to the axilla and the areola. Lucent centers, polygonal in shape and linear orientation. We have another entity, systemic disorder that can cause also calcifications in the breast is the hyperparathyroidism. Extensive diffuse vascular calcifications and diffuse coarse subcutaneous calcifications. Also we can find parenchymal calcification. This picture is with hyperparathyroidism. You know the hyperpara do extensive calcifications everywhere in the body, and being part of the body, they can occur in the breast. So there is extensive vascular calcification, there is parenchymal calcification, and there is subcutaneous calcifications. Systemic lupus erythematosus. Systemic lupus is a multi-system autoimmune disorder also. It is a rare chronic inflammatory reaction of the subcutaneous fat, which may occur in 2 to 3% of cases, known as lupus mastitis. The lupus mastitis, it is a chronic inflammatory reaction of the subcutaneous tissue. I was having a picture for a breast showing lupus mastitis, but I removed it because sometimes it's against rules. 2 to 3% of patients with systemic lupus may develop this entity between 20 to 50 years age. Lesions are often firm, 3 centimeter masses, may or may not be tender. Epidermal changes of atrophy and ulceration may be present, and this is very important. If you find atrophic in the skin, usually ask the patient. Sometimes the patient didn't say from the start that she has autoimmune disorder, but when you found these changes, ask about any autoimmune disorder present. Here is the case. She has breast edema. Breast edema, there is the skin thickening. There is pathologically appearing lymph nodes, and this is very, very important, that in the autoimmune disorders sometimes you find a pathological lymph node. Here the lymph nodes appear pathological, and I take from them biopsy even the upper cervical. Note this lymph node was irregular in shape, I don't know why, but when we take biopsy it was non-specific, and there is no malignant infiltration of these lymph nodes. So usually the autoimmune disorder may cause this worrying appearance of the lymph nodes. These patients usually are taking cortisone, and under the cortisone you can find many abscesses in the breast. This is abscess in the breast. This is the appearance of the abscess. Has a thick wall and posterior enhancement. There's another one here. So this is breast abscesses on top of taking cortisone. Breast granulomas also are special types of inflammation characterized by accumulation of macrophages, and some of them found giant cells. Granulomatous inflammation is usually characteristic of TB, fungal infection like histoplasmosis and coccidioidomycosis. Sarcoidosis also may affect the breast, and reaction to foreign body, and this is very important in cases of breast implants. Sometimes we have granuloma reaction to the implant present. TB of the breast. TB of the breast is a rare disease and is reported incidence only up to 0.1%. However, it has manifestations. Many manifestations may affect the breast from TB. The most important is the presence of lymphadenopathy. When you found a caseating lymph node in the axilla, then you should think of TB. It may present as a solid mass, it may present as abscess or cyst, and when you aspirate this abscess, you found caseating material, red or thickened skin, duct ectasia, texture changes in the breast, sinus or fistula affecting more with the TB rather than the non-specific infection. The most common mammographic findings in TB are trabecular thickening due to the presence, like the inflammatory process in the breast, but it is a specific inflammation. So we can find the trabecular thickening and skin retraction. Ill-defined breast mass may be seen here. Ill-defined breast mass. This is the most common findings. This is TB lymphadenitis. Note this case. There was a caseating lymph node in the axilla, and this is the caseating lymph node appearance on ultrasound. So this TB lymphadenitis. Another case, it was chronic due to here there is calcification present in the wall of this case. The breast, there is no affection in the breast parenchyma, but here there is a caseating tuberous lymph nodes in this case. And this case also, she was presenting to us as she has hard breast mass. The first presentation to the case was that she has a hard breast mass. Of course, when we see the mammography at first, we could not see this ill-defined shadow present posterior. This is very important. When you get craniocaudal view, you must see the tip of the pectoralis major muscle. It's not seen here because of this hard lesion. We could not pull the breast well. On ultrasound, there is a moth-eaten appearance of this rib, and there is a fluid present. This is a cold abscess of the rib presenting as a breast mass. We do for the case CT and MRI, and this was the cold abscess. And here also there was a paraspinal cold abscess present and ill definition of the vertebrae, and strangely enough that the patient did not complain of it. And here this is the cold abscess of the rib that present as a hard breast mass. So this is of the extra thoracic manifestations affecting the breast. Then we came to sarcoidosis. Sarcoidosis also is a systemic disorder characterized by the presence of non-caseating granulomas with proliferation of epithelioid cells. Sarcoidosis commonly affects young and middle-aged patients with a slightly higher prevalence in women. Involvement of the breast parenchyma is rare manifestation of sarcoidosis, presenting only in 1% of cases. Then in all what the cases we see before, all are rare, only 1%, but we must know the rare in order to diagnose. Primary breast involvement can be considered exceptional. It manifests clinically as firm to hard masses, often mimicking carcinoma. Breast involvement may result from intrinsic parenchyma involvement by granulomatous inflammatory process or from lymph node enlargement. This is breast sarcoidosis. At mammography has been described as irregular or ill-defined masses with being suspicious for carcinoma. This is an ill-defined irregular masses. Although small, well-defined rounded masses have also been described. We can find irregular ill-defined masses, and we can see also small rounded masses. The small rounded masses may represent intramammary lymph node involvement, calcifications absent. Ultrasound are also indicative of malignancy with irregular hypoechoic masses. And here is the appearance of the lymph nodes. They are so suspicious pathological. Eccentric hilum and there is thickened cortex, but on biopsy it reveals sarcoidosis. Of course, we are lucky if the patient knows that she is a case of sarcoidosis and she tell us. Breast lesions secondary to major organ failure. This is very, very important entity. This is the more common of the systemic breast disorders, but we put first the more warning. Bilateral or unilateral breast edema as part of the generalized edema in patients with congestive heart failure. On mammography, marked diffuse unilateral breast edema with skin thickening, as in this case, no underlying masses or lymphadenopathy seen. This is the typical reticular pattern of the edema pattern. There is global increased density. So, why it is unilateral? Because the patient is usually lying on that side. So sometimes the systemic breast edema may be unilateral, but in most cases it is bilateral. Here there is minimal edema also in that case, in that site. Breast lesions secondary to coagulopathies, and this is very important, coagulation disorder. Not only in the breast, sometimes we found pelvic hematoma, and it is related to intake of anticoagulants, or the patient has coagulative disorder. Breast hematomas are common after trauma, surgeries, or contusion. They are very rare, spontaneous. Hematomas occur spontaneously in patients with hematologic disease or coagulation disorders, and this case is an example of that. This case was a female, 22 years old, and she's coming to us with a hard breast lump. And on doing mammogram, it's not one, it's two breast lumps, and on ultrasound, they are macrolobulated appearing lesions, but very important here is to put Doppler. They are not vascular on color Doppler. And then on inquiring with the patient, we found that the patient, she has idiopathic thrombocytopenic purpura. She's not confronted with a major trauma, but when she left her child, he usually hit her slightly in the breast, and so she developed that hematoma. So that was a case of idiopathic thrombocytopenic purpura with hematoma in the breast. And this is on follow-up. This is a fluid level seroma occur in the upper part. Neurofibromatosis of the breast, another very rare. They are common in neurofibromatosis type 1. Neurofibromas are oval or round cutaneous lesions with circumscribed or partially obscured margins that did not show calcification or surrounding parenchymal distortion, like this one. On ultrasound, they elicit a hypoechoic ecotexture and may show distal acoustic enhancement resembling a cyst, thus causing misdiagnosis. Then we have again vascular calcifications related to atherosclerosis. Presence of vascular calcification on mammogram is strongly correlated with cardiovascular risk factors, and we do many researches before on that entity. But there is some diseases that may enhance this calcification, like diabetic patients. We can have in 50 years the patient has marked vascular calcifications because she is diabetic. Endocrine diseases, diabetic mastocytopathy typically present as palpable breast mass that may or may not be tender. So later, sometimes in diabetes, they did not feel the typical tenderness or pain of this inflammatory process. Solitary or multiple, unilateral or bilateral, it is commonly identified in premenopausal women with long-standing type 1 diabetes. Diabetic mastopathy accounts for less than 1% of benign breast diseases, but can present in up to 13% in patients with type 1 diabetes. So we find the inflammatory process in the breast in non-lactating female. First question, ask the patient if she's diabetic or not. Mammography is typically seen as solid mass with asymmetrical density, or it may appear as architectural distortion with features highly suggestive of malignancy. On sonogram, the lesions have concerning appearance. They may be irregular hypoechoic masses with worrisome features, and sometimes we need to take biopsy. If the patient has an unknown history of diabetes, it is possible to make diagnosis of diabetic mastopathy in core needle biopsy. Then we came to other endocrine abnormality is the presence of gynecomastia in male, of course. Gynecomastia associated with increased level of estradiol and decreased level of estrogen. Physiologic changes at puberty or endocrine or hormonal disorders, systemic diseases, neoplasm and drugs, all that may cause gynecomastia. Then we can take a home message. Both benign and malignant systemic diseases can clinically manifest in the breast as on routine breast imaging. Some findings of systemic diseases may mimic primary breast carcinoma, necessitating tissue biopsy or definitive diagnosis. Awareness of the clinical and imaging characteristics of the breast manifestations help to ensure appropriate diagnosis and management. Thank you.